Hello, everyone, and welcome to another Isrrt webinar on the 29th of October, 2023. My name is Steve Lacey. I am the Director of Education with Isrrt, and I also work as a radiographer at the Royal Children's Hospital in Melbourne, Australia. It's great to have you all on today, and I would like to start by just introducing our President of Isrrt, Dr. Napapong Pongnapang, to just say a few words.
Hello, good morning, America. Good afternoon, Europe, Africa. Good evening, Asia and Australasia. Welcome back to the Isrrt Facebook Live. And today's program will be another exciting program about the role of radiographers and radiological technologists in the CathLaB. So thanks to all the speakers from all around the world who come to contribute your work and expertise so that we can share all your knowledge and expertise to the radiographers and technologists community globally. Thank you very much.
Thank you, Dr. Napapong. Just a reminder that if you do have any questions, just to put the questions into the Facebook Live chat, and then we will ask the questions at the conclusion of the event today. So let's get started straight away. We are going to hear from our first speaker, Mrs. Angeliki Kalida. She is a radiological technologist in interventional cardiology department in General Hospital Aklapio Vula in Greece, and she's the treasurer of the Pan-Hellenic Society of Radiological Technologists. Her major areas of interest are cardiac angiographies, radiation protection, and patient safety. She is committed to promoting radiographer role development. She received her secondary education in Athens in Greece. In 2010, she graduated from the Technological Educational Institute of Athens as the radiological technologist. And 5 years later, she obtained her Master of Science in Neoplasms in the Human Body in National and the Kapodistrian University of Athens School of Medicine. Her working experience started from 2011 as a radiological technologist in the X-ray department in a large public teaching hospital for 8 months. When she graduated from TEI, she had been specialised on positron emission tomography and CT. She fulfilled her dream to work in the PET-CT department in a private hospital for 4 years before she commenced working in her current job. Her research experience started in 2017 as study coordinator in the cardiology clinic. Furthermore, she has an additional training in basic life support, good clinical practice, and safety reporting for clinical trials. She was awarded from the National Scholarship Foundation for the distinction during the academic year of 2007 and 2008 in the Department of Radiology and for the top 10 ranking in the Department of Radiology. Apart from an Isrrt Council member and regional coordinator for Europe, Isrrt, she's a member of the European Society of Radiology, or the ESR. She's also a member of the Association for Cardiovascular Nursing and Allied Health Professions, and a member of the European Association of Percutaneous Cardiovascular Interventions for Nurses and Allied Professionals from 2022 to 2024 committee. And she will represent EAPCI Allied Health Professionals in European Cardiology Society, or ESC, for the following 2 years. Welcome, Angeliki, on your talk about the basic role of the CathLaB. Thank you.
Hello to everyone. My name is Angeliki Kalida, and I'm a CathLaB radiographer at General Hospital Aklapio Vula in Greece. I'm a regional coordinator of education for Europe, Isrrt, and a member of the European Association of Percutaneous Coronary Intervention for NAPS, Nurse and Allied Professionals Committee. I will talk about the role of radiographers in the CathLaB. There is no conflict of interest for this presentation. A CathLaB is like this image. There are interventional cardiologists, CathLaB nurses, and CathLaB radiographers. Altogether, we are a team. All we have to follow these 3 pillars of radiation protection: justification, optimization, and dose limits. As concerns the justification and optimization, These two pillars confused during a PCI, a percutaneous coronary intervention, and especially when we have to choose if we have to continue with any new procedure, such as if we have a chronic total occlusion. So interventional cardiologists have to think about the benefit and the cost for the patient's life. As constant optimization, we have to follow these three basic principles: time, distance, and shielding. And CathLaB radiographers are in the room for these three basic principles. As constant the time, optimizing time is an interventional procedure which considers number of images, number of X-ray pulses per image, number of retakes, and number of CNS, and their duration and frame rate. Apart from that, we have the human efficiency, which means in the CathLaB, we are a team. We need to have an excellent efficiency, not bad, not poor, not just good, because we're talking about patient's life. As for the distance, we have to know when the beam is on. Check where the tube is. Check where the X-rays enter the patient and will be scattered. The patient is the source of radiation. That's why we have to keep distance. We have to put the tube under the table. And of course, interventional cardiologists should avoid a place next to the tube. So we are in the room to explain him all these procedures and where they have to stay and be protective from radiation. So we have to step back from the patient and preferably be hand shielding, and don't slouch over the patient, but stand upright. Of course, interventional cardiologists cannot keep their hands, have to keep their hands out of radiation field. We are here to tell them, and to nurses also, but of course put the detector flat panel as close as possible to the patient. This is our job. And of course, if we don't need someone in the room, such as when we have two CathLaB nurses, one of them can leave the room. Of course, using powered injectors for contrast material injections is preferable. We need to have an ergonomic room and place the motors away from the X-ray source. And of course, we have to analyze the danger that have any procedure and danger of radiation exposure for a patient and the staff, the whole staff. As for the shielding, lead shielding is critical for the protection of the medical personnel. Lead apron, thyroid shield, a eyewear, sling-mounted lead shield, as you can see on the left image, table-side shields, and protective garments of approximately 95% of scatter radiation. And we have to check our aprons for cracks regularly. This is our jobs, of course, with medical physicists. We have lead aprons, new lead aprons with the lightweight and ultra thin. Apart from that, we have a rampart, a zero gravity, and we are here and responsible for that because we have to use it correctly. We have to move them and set up. Of course, we have an extra medical devices, extra for shielding, which is these two, as you can see in these images, the star systems and agonist. They can minimize scatter radiation, both of them. And of course, they provide radiation protection to the whole CathLaB team. So even all of us have the best PB, always needing to be careful with the radiation. So I think that it would be better to create a radiation awareness culture, because we are a team. We are here to help them, to protect them, but everyone have to think about it and have this culture about radiation. So in the CathLaB, we have to keep calm, and we have to use it radiation as low as reasonable achievable, because in the room we're not just only for 1 or 2 minutes. Sometimes when we have a complex PCI or a chronic total occlusion, we can stay in the room for 2 or 4 hours. As concerns the dose limits, as concerns the staff, everyone knows that the whole body limit is 20 millisievert per year. And as concerns the patient, there is no limit, but we have the DRLs. The DRLs are the diagnostic reference levels, as a level used in medical imaging to indicate whether in routine condition the dose to the patient. Of course, it is a practical tool to promote optimization, to promote improvements in patient protection by allowing comparison of current practice. There are national and local DRLs. Should be set for each examination or procedure, for each clinical indication and each patient group. As concerns fluoroscopy and interventional radiology procedures and cardiology procedures, Isrrt area product is the recommended primary DRL quantity. What we have in the room, what we can see as CathLaB radiographers, and what is our job? We can see everything from all of this in the room, in our screen. We are responsible when the beam is off and where the beam is on. X-ray on, X-ray off. We can see where is our table. Is high or not. We don't love to see this -6. I prefer +6 and more than that. Of course, we can see the flood detector, the magnification. Another thing that we can see is the frames per second. We prefer 15, and in some medical devices we have to choose 7.5 per second. Of course, we can choose the fluoroscopy. Here, for example, is normal, but we can use to use low or high. It depends the patient, the body mass. We can see, of course, exposure time, and we can see, of course, the Isrrt. And we can say to interventional cardiologists and have a conversation during all the procedure that if there is a lot of radiation exposure, we can stop any procedure if we don't have any result. Apart from all the previous ones, how we are concerning, we're responsible for imaging. We're in the room, we have to be careful. We have to use collimation and filters and be focused on the subject, just not be open everything. We have to choose, we can choose what image is correct, is okay to get in the CD, and what is not. To conclude, a radiological technologist provide and ensure image quality, and of course follow the radiation protection rules and principles, both for patients and personnel. But in the CathLaB, patient's life comes first. Thank you for your attention. It would be a pleasure to be here with you today.
Thank you, Angeliki, for that very good introduction to the CathLaB and what and how that actually works. Our next speaker is Matteo Longoni. He is a radiologic technologist from Italy, and he is the valve coordinator for the Heart Valve Center in the Cardiac Surgery Unit in the San Raffaele Scientific Institute in Milan. Matteo is going to be talking about the extended role in the CathLaB. So thank you, Matteo, and welcome.
Hello to everybody. My name is Matteo Longoni. I am a radiographer and I am a valve coordinator at San Raffaele Hospital in Milan in the cardiac surgery interventional radiology department. It's a big pleasure for me to be here to participate to this webinar, to this event. A special thanks to Angeliki for the invitation. I do not have any potential conflict of interest, and I'll bring you our organization for radiographers that is composed by 3 years of medicine and surgery university with the purpose to train health workers who pursuant to the article number 3, paragraph 1 of a law of the 10 of August, the law number 2051 of the 2000, 251, sorry, of the 2000. The number of tests is 24. The final one has the value of examination of states qualifying for the professional practice. What about exam subjects? During the first year, we have to follow some basically subjects like anatomy and physiology, chemistry and biology, mathematics, informatics, radiation protection, our must, radiological semiotics, musculoskeletal, and obviously the English. During second and third year, we have to follow some more propedeutic subjects like general and clinical pathology, CT and angiography techniques, anesthesiologists, internal medicine, MRI, pharmacology, and like you can see other like radiotherapy, nuclear medicine, just to give us the opportunity to choose the best place for us to work in. After that, not to stop studying, the student, or better the radiographer, the new radiographer, can follow master's degrees in echocardiography, for example, like me that I've done a lot of years ago, or a master's degree in health management, or a second level degree in sciences of the health professions diagnostic techniques. If we make an overview in Italy, but I think that was the same in all over the world, about the activity of our CathLabs, we can see a real improvement in number of procedures. For example, this is a graphic about percutaneous angioplasty that show us that in the last 5 years we had a continuous development in numbers of procedures until 153,000 procedures cardiac angioplasty a year. We are organized in Italy in more or less 290 CathLabs. The same has been for structural procedures that have seen probably an improvement, if I remember well, more or less until 40% in Europe in number of procedures. What does this mean? This means that probably, like the activity of our labs, also our knowledge, our formation has to be developed, or is already done, or is we are in training on this, because we work, in my opinion, in a keep. We work with the interventional cardiologists, we work with nurses, with anesthesiologists if it's necessary, and we have to develop the capacity to collaborate with them during our activity. We have to have competencies for pacemaker and ICD implantation, for example, to manage emergencies like pericardiocentesis, rescue PTCA, standard PTCA or structural procedure like TAV, PFO, and MitraClip. We work in a keep with other colleagues, physicians, nurses, other radiology technicians. So this means that is important for us to develop also a capacity to work in team, to work in a keep, and in my opinion is not so easy. During procedure, a radiographer has to be confident with the sterile field, the injector of medium contrast, and the use of devices like stents, thrombus aspiration systems, intra-aortic balloon pump, and etc. But a radiographer has also to be well prepared, with enough formation in anatomy of the heart, obviously, but also of all vessels, and also to physiopathology of the heart, just to help and to work in the best way he can. But we have also to be trained in emergencies like ventricular fibrillation, cardiac arrest, the use of ECMO and other systems like that, or for the RCP maneuvers, okay? We are moving probably in our job to work not only with radiographers like we remember a lot of years ago, but we are moving to work like clinical technicians, radiology technicians. In fact, for example, for us, a new colleague that has not already experience in interventional cardiology has to be trained in a period from 6 months to 1 year before to be alone in routine, especially for emergencies. But we have a lot of problems. The first organization problems. The first one is that probably we have not a common organization and formation in all centers. We have not the same experiences in different parts of Italy. And in my opinion, this is crazy because the cardiac pathology, the cardiac patient, the activity of the CathLaB should be the same in all parts of my country. What about Europe? We could discuss a lot about that. Probably is the same. We have a lot of aspects like other parts of Europe. I'll bring to you the information that I obtained by other colleagues just to share what I think about and what I've said before you. For example, in Greece, a student has to pass 4 years of education about all modalities, and the last year can choose and can be specialized with his thesis. If the thesis, the job is different, if the thesis is different from the job, there is the opportunity to have help, to obtain help from other colleagues, to learn the job, and to have you have also the opportunity to study alone or to go to other hospital to be trained and to have other experiences about your job. There is no degree, and especially for CathLaB radiographers. In Holland, probably is the same as Greece, but there is an extra 1 or 2 years of education only for CathLab's employers. In France, for example, recently in 2012, to be precise, a university degree has been created for the paramedics in interventional cardiology, intended for paramedics who work in interventional cardiologists, and there is no, is not an obligated, it is not mandatory to have this certification to work in interventional cardiology, but obviously can help you to work better with less stress, with best quality of job. But unfortunately, like probably in Italy and in a lot of other parts of Europe, there is not a salary increase if you obtain it and if you work in a very specialized department. What could be the solution? I have not the correct answer, you know, but probably like us in Italy, we, with the help of GISE, that is our biggest interventional cardiology scientific society, we published in 2016 our position statement document to try to standardize the activity of our CathLabs, to increase competencies of nurses and technicians, and to increase the quality of our job. Don't forget that it is very important to use the opportunity to compare our experiences, to share our knowledges with all over the world, and to use in the best way and as much as you can the contacts, the networking that you can have with our major scientific society, like International Society of Radiographers, PCREA-PCI is the European Society of Cardiology, and the European Society of Cardiac Radiology. This is the, in my opinion, the best way to develop our knowledges and our job. In conclusion, I think that it's very important to have, could be a target for me to have the same education in all university and hospital, at least in the same country, and to have a strictly collaboration between other colleagues like nurses, physicians, and to everybody who work in CathLaB with us, and have intercultural experiences.
Thank you, Matteo, for a very good introduction to the role of the radiologic technologist in Europe in the CathLaB. Our next speaker is going to be Matteo Migliorini, also from Italy. He is a radiology technician working in the CathLaB since for more than 15 years in University Teaching Hospital in Ferrara city in Italy. He is a full member of the Italian Board Committee, Cardiology Interventional Nurse and Technician Professional Group. He is a full member of the EAPCI NAP's Board Committee. And Matteo is going to be giving us a talk about the extended role in the CathLaB. Thank you, Matteo.
Hello to everyone. My name is Matteo Migliorini. I'm a radiology technician, and I'm working in the University Teaching Hospital City of Ferrara in Italy. I've been working in the CathLaB since more than 10 years ago. In the next few minutes, I would like to explain you and to engage you with the extended role in the CathLaB. First of all, please, I would like to thank to all the International Society of Radiographers and Radiological Technologists to invite me to have the opportunity and the chance to be here in this wonderful and exciting webinar. So let's keep on. And the very first step I would like to show you is that the radiology technician in the CathLaB, the advanced role, one of the advanced role is absolutely to guarantee, to enhance, and to support safety first. I mean that safety first has to be a mandatory achieve and the mandatory element of the daily practice in the CathLaB for the radiology technician. Not only in the CathLaB as well, but during this webinar, we would like to show you and explain you the advanced role in the CathLaB for the radiology technician. The safety first is every day, every time, every patient, every moment we perform a task. You have to know that safety is a paramount. Safety is a continuum. Every task we perform, we have to perform it in safety condition. To put in the CathLaB every help and every support to achieve and to guarantee safety first. So safety first starts here. As you can see, think safe, work safe, be safe. You have first of all think about safety before to start every task, before starting every element to guarantee patient safety, to guarantee safety. And this is a very important topic in the working day, the routine day of radiology technician in the CathLaB, because the radiology technician in the CathLaB have to perform, have to engage with all the staff, with the patient as well, to guarantee, as I told you a couple of minutes ago, all the staff safety, all the things about patient safety. So you have to start beginning, at the very beginning, start with think safe, because think safe, it allows you to work safe and then to be safe. One of the most important element to guarantee safety as a paramount in CathLaB is its safety communication, because communication is one of the elements that affect safety more than 50% according to WHO and Joint Commission International data. You have to know that safety communication has to be every moment, every task, every procedure we perform in the CathLaB. And the radiology technicians have as a role, as an important role, and the most important role, and the advanced role at the beginning, from all the staff and the patient, all the staff and the other professional in the CathLaB. So put in the place safety communication is absolutely mandatory to guarantee patient safety. And the radiology technician is an important ring of all the chain of safety, and safety communication, it's one of the most important elements. Remember this, safety communication. And you can see and you can know as a radiology technician in the CathLaB that CathLaB is a very complex word. Complex word from brackets, but it's really, really a word inside the hospital, because CathLaB in the last year has to become a really complex procedure, a really complex activities to guarantee the very best outcome for the patient, the very best outcome in accountability for the patient. So you can see human and organizational factor that strongly interact into daily practice in the CathLaB. And the radiology technician, the advanced role of the radiology technician has to guarantee each one of this complex word, not more, not less important in the safety critical communication. I put in the red one, in the red box, because safety critical communication is just one of the elements of this complex human and organizational factor. As you can see on the left, managing human reliability, usable procedure, training and competence, staffing and workload, organizational change, then safety critical communication, designing for people, fitness for work, health and safety culture. And last but not least, maintenance, inspection and testing error. So you can just to see in this simple slide that the extended role in CathLaB for the radiology technician in the recent year has to become really, really more complex, really, really more huge. And the radiology technician has a critical, very important role. And in this place, in this complex situation, safety critical communication is just one element to guarantee, to achieve, and to enhance safety and patient safety. As you can see, I have put a radiology technician exactly in the center of this complex world, because as I told you just a couple of minutes ago, radiology technician has a role very, very important to collect and to guarantee the connection, the right connection, the safe connection, the usable and the reliability connection for all the staff and for the staff and the patient. According to this, connecting with patient is one more extended role in CathLaB. Radiology technician have to be in strongly connect with the patient, to put the patient at the center of all the procedure, because the patient is our main objective, to put the situation safety, to put the situation in a condition, in a manner that all have to be go right, all have to be go safe, all the outcome for the patient, not only just to the procedure, but to all the patient journey. As you can know, the patient journey is when the patient is coming from the cardiology ward, then into the CathLaB room, then again into the cardiology ward again. So all the patient journey, and the radiology technician, the extended role of the radiology technician is to be known about all the patient journey. Then the 5 C's to effective safety communication. This is a role, this is extended role that a radiology technician has to know about safety communication. When we communicate with the patient, when we will communicate with all the staff members in the CathLaB. We have to be clear, we have to be concise, we have to be complete in the message, we have to be courteous, we have to be consistent. So these are the 5 C's of safety communication according to WHO and according to Joint Commission International to achieve, guarantee, and enhance safety and patient safety. Because you have to remember always that we are here for the patient, for the patient-centered care. We have to always engage patient with all the staff, with all the procedure. So, in conclusion of my very short presentation, but I hope that it could be useful and helpful for you all. The extended role in CathLaB for the radiology technician, first of all, achieve, enhance, guarantee safety and patient safety, safety for all the staff, safety for all the procedure, and patient safety, because patient safety is a paramount for all the care we have to guarantee to the patient. Guarantee efficient and effective communication with all staff members. This is absolutely an extended role in the CathLaB for the radiology technician, to guarantee efficient and effective communication with all staff members, between all staff members, as a ring of the chain of the, as an important ring of the chain. Then patient engagement, to guarantee more safe, reliable procedure. The patient safety, the patient engagement, the extended role of the radiology technician is absolutely to guarantee and to engage patient, to guarantee a more safe and reliable procedure. I would like to thank you all for this opportunity and to thank you for being here. And I hope really that my brief presentation could be useful and helpful for you all. Thank you all. Thank you very much. Thank you.
Thank you, Matteo, for a really good talk and very important, I think, about communication. It's a very important topic when it comes to the role of the radiographer in the CathLaB, as well as in other areas of medical imaging. Our next speaker is Mr. Christopher Steelman. Mr. Christopher Steelman is from the Weber State University in the United States. He's an assistant professor. He's the director of the MSRS Cardiac Specialist Program, the director of the Cardiographic Technician Program, and the School of Radiologic Sciences. Christopher is going to be giving us the education perspectives from the American regions for the CathLaB. Thank you, Christopher.
Hello, my name is Chris Steelman. I am an assistant professor and the director of the Cardiac Specialist Program at Weber State University. And I'm honored to be here. I'm always thrilled to speak at an Isrrt event, especially about the CathLaB. So today we're just going to be speaking about what's happening in America. How do we become a CathLaB technologist? What is the process for acquiring that credential? And where are we going from here? As well as some of the challenges that we have in the here in the United States. So that's a little history, a little fun history. Werner Forsman, 25-year-old fellow at a hospital in Würzburg, Germany. He wanted to do research on inserting a catheter into the patient's arm, and so he could deliver drugs directly to the heart. But no approvals were in Werner's future. So he decided he would perform the experiment on himself. So he convinced a nurse to give him a 35 millimeter urethral catheter, and he proceeded to get access to his artery and insert that catheter into the heart. And in order to document that, Warner went to the imaging department, where a radiographer captured this image of the first human heart catheterization. And it almost represents the marriage of cardiac catheterization, interventional cardiology, and the medical imaging professional, the radiologic technologist. Now, years later, we see an interesting image. This is a picture of the right coronary artery, and it was taken by Mason Sones. Now, Mason was performing an aortogram because it was thought that if the catheter slipped into the coronary artery, the patient would go into a lethal arrhythmia. Well, in fact, that patient did. But this image was captured, the first image of a right coronary artery, which has now given us the ability to address coronary artery disease. But we're doing far more than that in the cardiac cath lab. Today, we are working in neurology, interventional radiology, and pediatrics. Now, as our profession grows and as the procedures that we do grows, they become more and more sophisticated. But we're able to address patient populations we never dreamed of. For example, in pediatrics. And there's no picture more beautiful than this: pediatric pulmonary artery system or pulmonary system. And it's through this harnessing of our knowledge of the radiologic technologies that we're able to capture images like this and guide physicians in interventions that change people's lives. So we're an integral part of the cath lab here in the United States. Now, here's one of our challenges: coronary artery disease. Basically, 1 in 20 adults age 20 and older have this. 2 in 10 deaths from coronary artery disease happen in adults less than 65 years old. And here's the one that always startles me. Someone has a heart attack every 40 seconds in the United States. So just in the time that we've been speaking, people have expired due to heart attacks. So in order to respond to that, of course, we have hospitals, 6,000, little over 6,000 of them, 5,000 of them have a cardiac cath lab. And we're starting to see those numbers increase. We're also starting to see these procedures being performed in ambulatory surgical centers, environments where they haven't been before. So growing number of cath lab, increasing number of hospitals is really creating demand for the radiologic technologist. Excuse me. So in the United States, the radiologic technologist is really responsible for 4 things: imaging, of course, fluoroscopy operation, panning, changing tube geometry, radiation safety, procedural assistance, monitoring, essentially in the control room, monitoring the physiological variables that are happening during the case. And then, of course, circulating. Now, what can you make in the United States with a credential in a cath lab? Well, in 2021, the median pay was about $60,000. And job outlook is growing faster than average here in the United States. So there's plenty of opportunity, and those opportunities are taking place in hospitals. Now, in order to work in a cardiac cath lab in the United States, we have different credentials. The preferred credential for the cath lab, surprisingly enough, is not a radiologic technology-focused credential. It is focused on cardiovascular procedures, and that's Cardiac Credentialing International. And they are supported, those specialists, by the Alliance of Cardiovascular Professionals. They're the society that sponsors webinars, continuing education, and things like that. On the other side of things, the radiologic technologists. Isrrt is the credential. We talked about the CI. Now, I've listed some things along the side that I've done for both of these organizations, but it gives you an example of the ways you can volunteer for either one, either the credentialing body or the supporting society, the ASRT. So if we look at who has these credentials in the United States. About 8,500 for RCIS, and a total of combining of the two credentials offered by ARRT is about 3,900. Now, how do we qualify for these? Well, the American Registry of Radiologic Technologists, the CI credential is a secondary credential, which means you go to school for radiologic technology for 2 years, and then you go on to get a secondary credential, and that can be in CT, MRI, and so forth. In this case, it's cardiac interventional radiography. Surprisingly enough, there's no academic preparation needed. You're simply passing a test and exhibiting that you've done a number of procedures. Same is true with the RCIS. You can go to school for both of these things, but there are paths to earning these credentials where there's no academic preparation. And I think that's one of our challenges. But let's talk about the test. And they're both very similar. They're split up essentially into categories, and those categories are based on a task inventory, which is a survey sent out to CathLaB technologists around the country. What are you performing in the CathLaB? And that keeps these tests relevant and up to date, which is very challenging in this rapidly evolving technology. But in order for either organization for that activity to be included, it must be reported by about 40% of the CathLaB technologists. And I think it's very important to note that they are both entry-level exams. And both of those exams also have clinical experience requirements. You need to do a certain number of repetitions in a certain procedure and record those and have them approved by someone qualified in the CathLaB. So here's our challenges. We've got rapidly developing technology making procedures possible that we've never even dreamed of. On-the-job training is simply not keeping pace for a number of different reasons. And academic preparation and the rules or the requirements for that is not keeping pace. There was a day I think you could be trained on the job, but that day has passed and we're doing sophisticated procedures. So that's one of our challenges. The other one is both organizations don't understand each other, and it's left people, qualified, academically prepared, and clinically competent professionals unable to work in some states. And the result is cardiologists are getting less and less service because in reality, we are there to assist them in medical procedures. We could be doing a better job with that here in the United States. And ultimately, patient care suffers. So there's a number of different ways to address this. Weber State University has always been known as one of the best schools in the country, if not the world, but the most innovative one. We've started a number of programs, including a master's degree in cardiovascular technology, where we're not just preparing people for examinations, but we are preparing them for research and advancements. They will be trained in 3D analysis, reconstruction. They have training in current trends in cardiovascular images that span the imaging spectrum. So we're doing some special things there, and there's many other schools in the United States at the associate's degree level and one or two at the bachelor's level. If you choose to take that route, an academic route, in order to become a professional in the CathLaB, those are your options. So it's quite exciting. We went from Warner Forsman, capturing a single still image of a catheter in the heart, and today we're using holograms. And the greatest thing about it is we're right at the center of it as radiologic technologists. We do have a lot of challenges. Our profession is relatively young, and I feel very strongly that things are only going to improve in the United States. And I look forward to reporting to you upon those improvements someday, perhaps maybe when we meet in Hong Kong. So I hope to see you all. Thank you so much, Isrrt. It's always cool to be here. And that's all. I appreciate it. Bye.
Thank you, Christopher, for that very intriguing discussion around the role of the radiographer in the CathLaB in the United States. And I've got a couple of questions that I'll be asking you at the end that I've come up with. Our final speaker for today is Mr. Glenn Ison. Glenn is the senior radiographer, senior medical radiation scientist, and section head of cardiac imaging at St. George Hospital in Sydney, Australia. He has 35 years experience as a senior radiographer in cardiac imaging. He's performed over 40,000 cardiac angiograms in attendance as the radiographer. He has published papers in cardiac angiography, intervention, and radiation safety. He's a multiple-time presenter at ECR in Vienna and at PCR, which is for cardiology. He's a member of the European Radiology Society, the European Cardiology Society is a professional member, the European Association of Cardiovascular Imaging, and the Association of Cardiovascular Nursing and Allied Health Professions. Glenn is going to be giving us a talk about the perspective of the radiographer in Australia in the cardiac cath lab. Thank you, Glenn.
Hello, everyone. First, I'd like to say thank you for the committee to ask me to talk on this webinar we have today. Thank you very much for attending. My name's Glenn Ison. I'm a senior medical radiation practitioner and section of cardiac imaging at St. George Hospital, Sydney, and on Australia-Asia Education Perspectives is the topic that I'm going to talk about today. Radiographer in Australia. Well, the titles are radiographer, medical radiation scientist, or medical radiation practitioner, depending on what state, which hospital you're working at. Qualifications currently is a 3-year university degree with a 4th-year clinical year, or a section head role like myself, MRI, CT, angiography is a bachelor's applied science, applied science minimum now. My section, diagnostic coronary angiography and cardiac CT, which I've been doing for over 33 years. And I have over 40,000 cardiac caps on my name as radiographer and procedures. And also, as everyone knows, last 20 years, cardiac interventions were taken over everything: coronary stenting, ASD closures, structural work, transaortic valve replacements, TAVIs, and EP now, an ablation. It's filling CathLabs up to full extent, and we're building more every day. We have 2 CathLabs in the public hospital and 4 other CathLabs in the adjoining private hospitals, and we're expanding with 2 more in the next 3 years. My special focus in this talk is radiation safety, which is I'm sort of known for a bit if you've been to a few conferences. My first paper was done back in 2015, which is lowering radiation dose procedures using spot fluoro, where we worked out a way to not just cone into the middle of the screen, but also cone into corners asymmetrically, so we could leave full fields and cone down to minimize radiation without having to move the table around everywhere. As you see, this paper that came out, we reduced by 21%. We have multiple publications in EuroPCR, which is the world's leading interventional cardiology conference. 2016, we presented an interesting case of dose-saving technology using a dose tracking system, where we worked out a way to actually measure peak skin dose throughout the whole procedure using conical sections of the beam as it went around. We got this off the road with a paper in Neurointerventional Journal, and this case, the first clinical case in the world that was shown, this one here, how we are not burning skin anymore like some cardiac procedures used to. There's so much radiation, by the ability to see where the radiation going and moving the beam around to lower it. We then move into working out scatter radiation, not just patient safety, but also staff safety. As you can see here, we started doing 3D mapping of cath labs and IR rooms, the vascular rooms, to work out the safe areas to stand and where does the radiation go for each view we do. We then worked out ways to reduce dose significantly by removing the grid on low BMI patients. In this paper that reduced International Journal of Cardiovascular Imaging. As you see here, we just did some correlations to work out this is a very effective way to lower dose, especially for cases where you don't need the image quality, like EP and pacemaker insertion, where we've lowered the dose dramatically. COVID, remember that time, everyone? Well, we did a bit of experiments then in stuck into it. We found a way using a Rampart shielding device to not only lower the radiation using this large attenuating acrylic shielding system, but also to work out ways, you see the middle slide, to lower COVID transmission by using laminar flow and filtration and acrylic screens to keep the patient away from the operators using the hepatic filters in the cardiac cath labs. As you can see, we're very effective head dose reductions using the system, as well as keeping the clean air onto the cardiology side and the patient's expired air onto the patient side. We also worked out ways to lower eye dose by adding on patient attenuating drapes. Everyone might use these themselves, where we can lower these emission scatter, but we worked out that it's not always effective in most views. Certain views is very effective, as you can see over here. When you're doing REO cranials, we get a lot of effective scatter attenuation, but you can't cover the chest totally, of course. So some views, there's very little, but it was still effective to use a safe start radiation dose. We've done quite well and won 2 awards in Paris, one from 2016 and also 2023. Our first one, which you see on the left there, we worked out a high procedure radiation dose found for the second operator, whether it's a registrar or the scrub nurse, because the lead shields weren't, the acrylic shields, ceiling mounted, weren't wide enough. As you see in the pictures there, there's an edge effect onto the nurse or second operator. So we now worked at Mavic to make every lead acrylic screen in the world now is a wider screen that's used for interventional work and IR in cath labs. And the latest one last year where we won the award is when we were trying to work out how to protect pregnant staff, especially registrars and female medical staff who want to get into cardiology or interventional radiology and are worried about dose. We worked out that there's quite a modern cath labs with adjunctive shielding, as you see in the pictures on the right, that we can get the dose down to quite safe levels, and there's nothing to worry about as an occupational way to go ahead. That went too far. Anyway, thank you for listening to the talk, and I appreciate it very much.
Thank you, Glenn, for a great talk on the advancements of the cardiac cath lab and how it's actually come quite a long way, I think, over the time. I'll invite all of the speakers just to turn their microphones, their cameras on, just so we can just ask some questions. My first question is just to Angeliki. Angeliki, there's obviously a relationship a professional relationship that is required with the proceduralist to ensure that the radiation dose is optimized with the for each of the patients. But particularly when you're trying to do something, if you're like, how do you communicate, I guess, with the proceduralist when you have your, I guess your priority is the radiation safety, but the proceduralist priority is, of course, to try to obtain the images in order to be able to help with the patient and that. How can we change that? Oh, you're muted.
Okay, I'm so sorry. Can you hear me now? Okay. Okay, perfect. Okay. Can you tell me again the question, because my English is not so good.
Yeah, that's okay. I think you as a technologist will have a priority to make sure that the radiation dose is optimized, and you have your priority of radiation safety. The cardiologist, though, will have the priority to make sure that they help to fix the patient. So where is the middle ground between your priority and their priority?
Okay. As I told in my presentation, we can see the screen. So we can see some numbers, some limits, and we are here in the room to have the conversation with the interventional cardiologist and tell them that now you have to stop or you have to continue if you think that you need only some or few minutes. Of course, they know the limits about the radiation. For example, when I say 2000 milligray as per the air camera, I can start and say we are 2000. Okay. And then I'm here to remember him every time, every second. Okay, and I can see if he's okay, if he's how to say it. If he's ready to stop the procedure or to finalize all the procedure, and everything will be okay. If it's not, we'll see. Because sometimes before all this, before we find the limit for the patient at the radiation dose, sometimes an interventional cardiologist says, okay, we cannot do all the procedure right now, so we may say to patient, come another day and finish the procedure, or we may need some extra devices, some extra wires and tools that would be more helpful for a patient and for interventional cardiologist, and the results will be the best for patient.
Yeah, thank you very much. That's a very good answer, I think, to make sure that we're monitoring the doses and letting them know when we have reached the dose limits for these patients. Matteo Longoni, just from the European perspective, what is the ideal education that you think for the CathLaB radiologic technologists? So, and we're talking about like the on-site learning in the university. What do you think is ideal?
Yes, thank you for the question. This is a very interesting point. I don't want to be unpopular about that, but probably you have to consider a rebuild of the formations program in our university from the beginning, just to change probably and to change it and to develop it in a common part in the few years of our educational program, just to change and to specialize it in the final part, choosing the direction that we want to follow. This by the side of the university. By the side of the centers, of the hospital, of our scientific societies, probably we have to develop a real program to sharing of experiences in other countries, in other university, or linking knowledges of all scientific societies. Okay, for example, you asked before to Angeliki, how is the link between these two aspects? I could answer you that probably I don't know what you manage. For example, patient that underwent to a very long coronary procedure to control the dose, to manage the safety of the patient. So probably we don't have in all countries the same way and the same program to manage this. And this show that the differences between all countries and sometimes between different centers in the same country is a point to change, a point to solve, to go everybody in the same direction and with the same program.
Yeah, thank you. I think there's such a variety, even across Europe, but across the world, I think, in terms of the education that is given and the amount of clinical placement time within the CathLaB as well. And trying to find an ideal is very, very hard, I think. It would be nice if we all had a very uniform way of doing it across the globe, but I think that's a long way before that happens, actually. So thank you for your answer. To the other Matteo, we're talking about the extended role, and you talked a lot about communication, and communication, of course, is extremely important. How can radiologic technologists overcome the barriers of hierarchy in the CathLaB to achieve a safe space? I talked a little bit about that question with Angeliki, but obviously within the CathLaB, there's a traditional hierarchy where the cardiologist may have more power, I guess, in some cases. And that how can we overcome those barriers to make sure that we still achieve a safe space?
Thank you very much, Steve, for the question. This is a very good point. This is a very the point in the CathLaB. But I mean that hierarchy, you know that at the very beginning of the safety and thinking about safety, it starts in the aviation science, when only the pilot had the mind and the power to take the control in the airplane. But in the several years again, and gone in the years forward, not only the pilot had the command to all the plane, but all the CRM, they call CRM, crew resource management. So they intend to the crew resource management is that all the single person inside of the plane has the leadership to take the hand and say, maybe we have a problem, or just inside to the CathLaB, I can explain with example that maybe me, for example, if I see in the monitor, if I see on the patient, if I see in the many system inside of the CathLaB that something is going wrong, I have to, not I can, I have to run my hand and say, amen, that's a problem. Or just, for example, we could have a chance of code, for example, meaning about a perforation. If I've seen in the imaging a perforation, I could say, look at the monitor, or just not to say, oh, maybe help, that's a perforation, because the patient, as you know, can hear us. So looking at your question, this is a very good question, because the hierarchy, it's a very problem to guarantee safety in the CathLaB, but not only safety, to guarantee a very good outcome for the patient. So we have to be more flat in the CathLaB. Flat, I mean to the communication, I mean to from the pairs, people at the same level. There not be a person at the high level or the low level, but we are all in the same, as I can see, in the same boat, for the patient, for the safety, for the good outcome, for the procedure. So let's remember that hierarchy is not a very good choice to think about good result, enhance patient safety, and so on. So thank you very much for the question, because we have to think about, first of all, for the patient, first of all, for the good outcome for the patient. Thank you.
Thank you, Matteo. I think you're right. We are now kind of moving a lot away from the archaic model of that hierarchy, I think, anyway. And very, very interested that you actually use that term around the aviation industry as well, because that's certainly something that I speak of quite a lot. At the end of the day, I think we all have a duty of care to our patients, and there should be no barriers around that duty of care from our perspective anyway. So thank you very much, Matteo, for that. Chris, moving on to you, I think you gave us a very good, at the start of your presentation, a really good look into the history of the CathLaB itself. And you also talked a lot about pediatrics, and me, of course, being at the Royal Children's Hospital in Melbourne, I certainly have a lot of interest in that, and I do get involved in the cath cases there as well. Given the challenge that you mentioned about academic not being able to kind of keep up, and also that on-the-job training isn't necessarily feasible given how quickly the pace is within the CathLaB itself. What do you think is the solution to this issue?
It's a great question. Excuse me. Thank you very much. Let me just take this opportunity, Steve, to thank you, Udafon, the Isrrt, for inviting me to participate on this incredible panel. 40,000 CathLaB cases. That's amazing to me. I think, I think we are at a crisis in the cardiac CathLaB, not just here, but internationally. Here in the United States, believe it or not, you do not have to go to school specifically for cardiac catheterization. And we, so as complex as the CathLaB is and the things that we're doing, the political environment is just as complex. And to bring in the various organizations who often, I just don't think they understand each other or have taken the time to. And so it's a difficult environment. I think back to my original point was, technology is evolving at such a rate, but our educational system and our approach to educating radiologic technologists in the CathLaB is just not keeping pace. So in the United States, the CIRRT radiography credential is secondary to a radiography credential. However, you don't have to go to any kind of training, and I'm not degrading the value of that exam, but if you can pass an exam and record a certain number of cases, you can work in the CathLaB. And I think that was great when we were doing stents and balloons 20 years ago. But now we're doing structural procedures on a variety of populations. As you mentioned, pediatrics, we're doing some incredible things there. So the solution to that challenge, if you were to ask me, and I might be a little biased because I am an educator, but I think school should be required in the United States. We're not just performing radiography surveys, but we're administering medications. We're sticking wires in people's hearts, and yet the education, formal education, is not required here in the United States. So I think that's an issue, and will continue to be until we look at what a cardiovascular technologist does. Is provide procedural assistance to a cardiologist. The imaging is just a component of that. And I think we're failing to put highly qualified, well-trained people in that role. And so, it's going to be interesting to see what happens over the next 10 years.
Yeah, thank you very much, Chris. And I think the other interesting point is, and I think that it's probably become quite obvious even in tonight's webinar, is just the large variety, I think, of the role of the radiologic technologist in the CathLaB. In some cases, it's very minor, but in other cases, it's very major in terms of how involved we are. And I think that education around that is extremely important. So thank you, Chris. Glenn, moving on to you, I actually have two questions for you.
Okay.
The first is a fairly simple one, because obviously me coming from a pediatric centre, we do a lot of removing of grids for a lot of our cases, particularly even our diagnostic cases or our interventional cases as well. Do you ever remove grids for the standard cardiac procedures, or is it just for your pacemakers and EP studies?
Basically, pacemakers, particularly, as we know, it's large bore metal catheters, easily seen. You don't need a high definition, and EP cases. But we're doing less than that now. That more NAVX is taken over, CARTO and all those type of things for EP. Most of the X-rays now use the guidance and cross-septal crossing of the catheters, and then we take over with the CARTO and other NAVX stuff. But pediatrics especially. When the first flat panel came out in 2000, I worked with GE because the FDA wouldn't actually comply because they couldn't get the frame rate low enough and the entrance dose low enough for pediatrics. So it stalled the production of the Innova system, if you're that old and remember the first flat panel. So I worked with them to remove the grid, and actually they just screwed a handle on it and made it part of the brochure. And that's how that all started millions of years ago. But then we actually, for a while, we started using different coarser and finer grids, depending on the patient BMIs. So we would get still some, decent imaging and less scatter, but we'd open it up or narrow the grid depending on what the patient BMI was. But now software, as you understand, has taken over a lot of that. And that's on our next research, is actually taking the grid out or even decoursing the grid, as software is actually AI, especially we're working with, can actually take away the aberrant photon numbers that scatter is and what the grid uses to mechanically, which we're working on AI at the moment to do that. And maybe if this goes ahead, in a couple 5 years, they'll be pulling gridless systems can be coming out using AI.
Yeah, that's fantastic to hear, I think, as well. And I think even just looking at it at face value and looking at the image quality that's coming out with the newer systems now anyway, there's certainly a big difference. And I think that the use of the grid, I think, is certainly diminishing over time. So it would be great.
70-year-old technology.
Yeah, absolutely. Yeah. Just one other final question, and that is just around, because obviously you come from Australia, and there is no real advanced practice courses or anything that revolve around the use of the radiographer in the cath lab, or even in interventional radiography. Do you think there should be a bit more as far as advanced practice, like more?
Yes, guaranteed. Most of our universities here, you can do your masters in CT, MRI, whatever, but angiography and IR, which is the highest radiation dose of all of them, there is no set master's program. Which what you find out, as you probably know, Steve, and around the world, is if you have a site where you've got one person or a couple of people are there for a long period of time, you get a highly structured, highly educated CathLaB system, and I'll be there forever. But if you get some sites where they just rotate the radiographers through, because there is no educational coefficient to go with that, the site has then become very low grade on the radiographer side. One, because there's no formal education, and two, they just rotate through. So as you know, Steve, we get around that by just usually hopefully having seniors in position long enough to create that virtual specialized education, which I then pass on to, I used to call it a semi-master's program we do in St. George, as we teach up, but we do definitely have to structure that. And Christopher, listening to your system, like America, how you have at least exams and things you can pass, is a lot better than what's happening to us in our country. So yes, Steve, we definitely need. I used to lecture at Sydney University with them for years and years, but yeah, we definitely did have this dedicated program, because IR and endoluminal land, as we call it now, everything's coming together. We really need to get up a speciality in all that cross-reference vascular, cardiac, IR, and have a specialized program. Guaranteed.
Yeah, thanks, Glenn. And I think that at the moment as well, it's even a challenge to get much in the way of angiography, particularly for clinical placement time for even your entry-level students as well.
Exactly.
And that actually makes it hard, and probably even more so a reason to probably include something advanced practice-wise for that anyway. So thanks, Glenn.
Absolutely.
And thank you very much to all of our speakers for tonight. I do want to actually give a specific thanks to Angeliki, who actually organised tonight's event in terms of organising all of the speakers and that. I think she's actually done a brilliant job. Thank you very much. To just moving forward as well, before everyone goes, our next Isrrt webinar is going to be on Wednesday, the 8th of November, which is World Radiography Day. That is actually in 10 days' time. We have 3 speakers lined up, and we're going to be just celebrating patient safety. So we have some good talks lined up in that. So please look on your socials for that, and keep an eye out for the advertising. But that event will be coming up shortly.
Thank you. Thank you to you.
Thank you very much. Thank you very much too. Thank you.